Thank you for letting us present. I would like to begin by acknowledging my co-investigators. This work was supported by NHTSA, which funds the NEMSIS program, and HRSA, which supports the CHAMP node of PECARN. There is a need to implement evidence-based practice to improve pre-hospital patient care. The evidence needed to effect change must be obtained using rigorous research methodology. In order to conduct high-quality prospective research, background data from retrospective studies are needed to describe the frequency of disease and exposure occurrence. A national data set of EMS responses and transports could be used to facilitate this type of research. The National Emergency Medical Services Information System, or NEMSIS, is a national repository of EMS patient care reports that collects 165 variables. The goal of the Pediatric Emergency Care Applied Research Network, or PECARN, is to conduct prospective EMS research to improve the care of children. To meet this goal, there is a need to rapidly determine the types and numbers of pediatric patients transported by participating EMS agencies. Combining data across EMS agencies at the local level, while technically possible, is complicated and costly. However, leveraging the NEMSIS data to extract PECARN data could be an efficient and cost-effective method of providing network-level data. The objective of this project was to describe the process of creating a PECARN-specific NEMSIS dataset and to determine if these data are nationally representative when compared to the complete NEMSIS dataset. If these PECARN-specific data are used for research, we need to understand the generalizability of the data compared to the larger NEMSIS dataset. In general, individual EMS agencies submit data to their state EMS office, who then provide data to the NEMSIS through a data use agreement, or DUA. These DUAs prohibit the release of data identifying an EMS agency. So to create the data set for this project, a separate DUA was required that would allow the NEMSIS to identify PECARN EMS agencies and provide only their data. Investigators approached both the participating EMS agency and the associated state EMS office and explained the project. If the EMS agency and their state office agreed to participate, they determined who would sign the project-specific DUA. In total, 19 agencies from 9 states completed a DUA. We conducted a retrospective analysis of variables within the PECARN-specific dataset compared to the national dataset for all pediatric events in 2019. No statistical analyses were utilized due to the large sample size. Instead, a difference of plus or minus 5% was deemed to be clinically meaningful. The PECARN-specific dataset included over 305,000 events, of which 6% were pediatric patients, 18 years old and younger. Of the pediatric events, 98% were initiated through the 911 system, and 55% were transported by the documenting agency. The national dataset included 10,062 EMS agencies, which conducted over 36 million events, of which 6% were pediatric patients. Of the pediatric events, fewer, 79%, were initiated through the 911 system, and more, 62%, were transported by the documenting EMS agency. When we compared the demographics between the PECARN dataset and the national dataset, we found that while there were slight variations in demographics between the two datasets, the two groups were similar in age and sex distribution. However, there were significantly more patients documented in the national dataset as Black or African American, 11% versus 23, and Hispanic or Latino, 4% versus 14. While the PECARN dataset had over 48% documented as unknown or not documented. This was more than double the missing rate for the national dataset. This comparison of the most common primary impression shows that injury, mental health, and seizure are common in both datasets. But weakness and pain are listed in the PECARN specific list, but not the national list, and general examination and acute respiratory syndrome are listed on the national list, but not the PECARN specific list. Finally, this table compares the number of procedures performed across the two data sets. It demonstrates that very few of the pediatric events involved documented procedures, and the rates of procedures being documented were similar across the two data sets. Specifically, cardiac monitoring was the most common and was only performed on just over 5% of cases in either data set. This was followed by cervical spine immobilization, which occurred in just over 1%, and all of the remaining procedures occurred in less than 1%. We have demonstrated that NEMSIS can be leveraged to create a cost-effective network-specific data set. The PECARN network's EMS data are similar to the national data, though racial and ethnic minorities and some primary impressions may be underrepresented. Additionally, more PECARN events originated through 911 and fewer were transported by the documenting agency. This is likely related to the type of participating agencies, their ALS response level, and the diversity of their communities. Finally, we found that pediatric procedures are rare and thus networks of agencies are likely needed to conduct pediatric research. Thank you for your attention.